There is a 40-year-old gentleman who had a RTA and then after had a trauma to his dominant wrist. He was seen in A&E with a close deformity of the wrist joint. An X-ray was done which showed a radial styloid fracture. A thumb spica splint was applied and he was discharged with a follow-up appointment in the hand clinic. An X-ray at the beginning showed a radial styloid fracture. There is a catch into this vignette because when you are in the hand clinic, you see the X-ray and the visible findings are slightly different than what is quoted. You examine the patient, there is moderate swelling of the hand of the metacarpophalangeal joint with sensations slightly diminished predominantly in the median nerve distribution. A PA and lateral radiograph reveals a styloid fracture, but there is associated displaced fracture of the waist of the scaphoid. No other abnormalities are seen. This vignette signifies that the radial styloid fractures, the forces can travel through the scaphoid as well. The differential diagnosis can be isolated radial styloid fracture with a scaphoid fracture, radial styloid fracture with scaphoid fracture, and a scaphoid dissociation or other perilunate injuries. There was an experimental study with loading 32 different cadaveric wrist joints with wrist extension, ulnar deviation, and intercarpal supination, producing 7 different types of radial styloid fractures. Most of these radial styloid fractures were from radiocapitate ligament avulsion rather than styloid tip fractures from radial collateral ligament avulsion. Non-displaced styloid fractures were commonly associated with injuries to the scapholunate ligament complex. The association of intercarpal injuries has been elucidated through the arthroscopic evaluation of intra-articular distal radial fractures. Indeed, 20% of intra-articular radial styloid fractures are found to have concomitant scapholunate disruption. Although the combination of scaphoid fracture with scapholunate diastasis is rare, it can occur in combination with radial styloid fracture as well. Transcapitate or transtriquetral injuries may also be seen with styloid body fractures, in addition to dynamic or static scapholunate instability. Radial styloid fractures without obvious intercarpal malalignment in patients who have suspected intercarpal ligament injuries may benefit from head joint wrist arthroscopic management. Please note that those patients which have acute partial scapholunate ligament tears associated with distal radius fractures are probably never warranted to proceed with any intervention. This patient was given a splint. 7 days after the injury, an operative procedure including open reduction internal fixation of the scaphoid with an anti-grade screw and a 0.05-inch K-wire close reduction and pinning of the distal radius fractures with K-wire repair of scapholunate interosseous ligament, intercarpal pin stabilization, and open carpal tunnel release was planned. The scaphoid was exposed through a longitudinal dorsal incision. The proximal pole of the scaphoid was found to be completely detached from the scapholunate interosseous ligament. Secure fixation of the scaphoid fracture was accomplished with an anti-grade Hub screw. Direct visualization of intra-articular radial styloid fracture assisted reduction before percutaneous K-wire fixation. Maintenance of proper capitulunate orientation was achieved with retrograde K-wire from the capitate to the lunate. The scapholunate joint was then reduced, and a 2.054-inch K-wires were used to maintain the normal scapholunate relationship. The carpal tunnel release was performed through an incision that crossed the distal wrist crease obliquely before terminating at the distal end of the ligament in line of the third web space. This example of a case illustrate consideration of all the sustained injuries. A repair of the scaphoid fracture first permits more fracture fragment mobility and make anatomical reduction easier. Following secure fixation of the scaphoid, the distal radial intra-articular fracture is reduced and fixed. Derotation of the extended lunate and fixed scaphoid with provisional K-wire joystick assist in K-wire fixation of the scapholunate complex. The dorsal surgical approach to the acutely fractured scaphoid permits clear visualization of the scaphoid fracture and further allow appropriate access to the repair of the rear intercarpal ligament disruption as well as reduction of the radial styloid fragments. A volar approach to the scaphoid could have been chosen. However, the additional volar incision for the radiocarpal release in the face of moderate swelling might compromise wound closure. It is hereby indicated that any patient having a scaphoid fracture along with carpal tunnel release requirement, it's advisable to approach dorsally for the scaphoid fracture. Arthroscopic management of the presence of acute carpal tunnel syndrome is a possibility. Arthroscopic management of the bone and ligament injury in this case might have been possible, but was not attempted. Moreover, when intercarpal pathology requires an arthrotomy, the radial styloid fragment reduction is simplified by direct visualization, which obviates the need for arthroscopic assistance. Sadly, in our case, the patient digital sensation did not improve. The patient returned 1 week with increasing pain and swelling in the hand and the fingers, further restricting range of motion. He was given 2 steroid packs, and additional narcotic analgesia. 1 week later, his pain increased despite no change in examination. He was placed by an intense transcutaneous electrical nerve stimulator unit, which improved his pain tolerance during the day. Just over 6 weeks after the injury, the patient was taken to the operating room for a removal of the pins. 2 weeks later, the swelling significantly reduced and the fingers were supple. The radiocarpal motion was non-crepitant and the X-rays continued to be normal except for periarticular osteopenia. Pain at this time persisted and no additional physical therapy was utilized. About 4.5 months down the line, the patient was back to the active outdoor activities of interest with occasional soreness. His wrist extension and flexion were 30 degree and 50 degree respectively. After 2 years, the patient achieved normal grip and continued to enjoy his diet.